So thank you everyone for joining us this evening. My name is Maddie and I'm going to be co-moderating the session with Dan March, and then we've got Sharlene, Greenwood and Jamie McDonald who are going to be presenting. So we're just going to do some quick introductions. So I'm on the GREX committee as a patient representative. I'm based in the UK and I run a consultancy advising medtech and healthcare providers on dialysis, and particularly around home dialysis. And I've got a real passion and interest for this, both because I want to kind of improve the future for kidney patients, but also because I'm a long-term home dialysis patient myself. And my real interest is in exercise. So I've been on dialysis at home for 23 years, and exercise has been a massive part of my long-term health and well-being, and doing nocturnal home hemodialysis, which in my opinion is gold standard, and 2 years ago enabled me to run a marathon after 20 years dialysing. So that's why I'm so interested in this study, and obviously helping patients who dialyse in centre to try and access some of those benefits as well. And I'm just going to hand over to Dan.
Introduction, Maddie. So for those who don't know me, my name is Daniel March. I'm based at the University of York, but previous to that I was based at the University of Leicester, and my main role there was coordinating the Cycle HD trial, which looked at the effect of a 6-month program of exercise on cardiovascular health in those individuals receiving hemodialysis. But tonight I'm really thrilled to be able to moderate this session along with Maddie, because we're going to hear about the PEDAL trial. So for those who are not familiar, the PEDAL trial was looked at the effect of a 6-month intradialytic exercise program on health-related quality of life, and our two speakers helped to run that trial. So that's Jamie McDonald from Bangor and Sharlene Greenwood from King's College in London. So first of all, I'll just introduce Sharlene, and then Maddie will take it over from there and introduce Jamie. So Dr. Sharlene Greenwood is a consultant physiotherapist at King's College Hospital and an honorary senior lecturer at King's College London and an NIHR postdoctoral research fellow. She co-chairs the UK Kidney Research Consortium and is the president of the UK Kidney Association. Sharlene has worked for over 15 years with people living with kidney disease, and this has mostly involved designing and evaluating different ways to motivate people to be more active. More recently, Sharlene led on the development of the Kidney Beam, which is a novel digital platform that was rapidly developed to help people living with kidney disease to help them manage their physical and emotional well-being during the COVID-19 pandemic and beyond. Sharlene leads on one of the only commissioned renal exercise services in the UK, which includes renal rehabilitation, weight management, and specialist kidney transplant exercise clinics. So thanks for that, and I'll hand back to Maddie, who will kindly introduce Jamie McDonald.
Thank you. Dr. Jamie McDonald did a PhD at Bangor University in Wales, investigating body composition in patients living with chronic kidney disease, and then a postdoc in the renal unit at Greenwood Hospital, which was studying fatigue. And he's now a senior lecturer in clinical exercise physiology at the Bangor School of Human and Behavioural Sciences. And he leads with the local health board on a kidney disease rehabilitation programme with exercise, and is the co-chair of the Kidney Research UK Physical Activity and Wellbeing Study Group. And he says when not working, he is always encouraging his 6-year-old daughter to be as passionate about outdoor pursuits as he is, which sounds like fun. So thank you. I will hand over, I think, Sharlene, you're going to start.
Great, so thank you, and really appreciate the opportunity for us to come and talk to you today. I'm just going to share my screen and hopefully that will all work okay. Okay, is that okay, Maddie? Can you see that screen all right?
Yeah, we can see it.
Brilliant. So thank you for the kind introduction, and we're going to be quite selective in what data we're going to present today, because Jamie and I want to tell you a story about the data, and if you want, you can read the full published paper for a more unbiased but less interpretive view as far as we're concerned. So okay. Right, so improved dialysis techniques and management of coexisting disease has made hemodialysis more tolerable, and many new patients can anticipate a longer life expectancy, although not always with a good quality of life. In particular, patients report multiple symptoms that impact upon the physical component of health-related quality of life, and a decrease in that physical component of health-related quality of life is independently associated with mortality and morbidity. Evidence from several systematic reviews indicates that a range of exercise training interventions have shown potential to improve exercise capacity and physical function in patients on hemodialysis. And of particular interest are studies that have investigated intradialytic exercise, as the environment of unit-based hemodialysis provides a platform to implement exercise rehab programs during our routine thrice weekly 4-hour-long hemodialysis sessions. However, very few hemodialysis units have chosen to implement this type of rehab option, with a barrier to implementation being a lack of high quality, adequately randomized controlled trials, which have included patient-reported outcomes, health economic analyses, and also a review of associated harms. So consequently, the PEDAL trial was commissioned by the UK National Institute for Health Research to evaluate whether intradialytic exercise training was able to improve health-related quality of life in patients with chronic kidney disease on hemodialysis therapy. So we conducted a pragmatic, prospective randomized controlled trial in 5 regions of the UK across a total of 12 hemodialysis units. The trial recruited 335 prevalent patients receiving hemodialysis therapy. The intervention itself consisted of using a modified cycle ergometer to perform aerobic exercise in a semi-recumbent position 3 times a week during the first 2 hours of hemodialysis over a 6-month period, and twice a week after the aerobic cycling, patients were also encouraged to complete lower extremity muscle conditioning exercises, which used either ankle weights or TheraBand of varying resistance. The exercise program itself was delivered and supervised by physiotherapy assistants. So the primary outcome for the study was the change in kidney disease quality of life using the short form 1.3 version of the physical composite score between baseline and 6 months. So the baseline demographic data of the trial cohort broadly aligned with the real-world dialysis population in the UK, as detailed from the latest renal registry report. However, the current study included a larger proportion of Black African and Black Caribbean participants and a lesser proportion of white participants. Okay, so looking at the results showed that there was a non-significant between group difference of 2.4 arbitrary units in the kidney disease quality of life SF 1.3 PCS. That's a bit of a mouthful, from baseline to 6 months, and no significant between group differences in any of the physiological outcomes. Compliance and adherence with the intervention was low. We had a particularly deconditioned group of participants that took part in the study. And from a safety perspective, there was no significant between group difference in serious adverse events. So they were similar across the 2 groups. Okay, so with that first bit of information, we want you to ask yourselves that based on the results so far that you have seen, would you advise your renal unit to invest in an intradialytic exercise program? I'm now going to stop sharing screen, and Jamie's going to share his screen.
So while you're thinking about that, thank you to Dan and Maddie, and to all of you for coming to listen to us today talk. Just going to fire this up. And swap. Okay, so can you see the slide now with pedals primary outcome at the top?
It just flicked onto your notes there. It was on the slide before.
Okay. Is that better?
That's it, perfect.
Okay. Okay, so so let's try to look at this data in a little bit more detail. So for the primary outcome, which was physical component summary by the SF36, the mean difference in the change in PCS from baseline to 6 months, the mean difference between the exercise and control group was 2.4 units. And you can see the 95% confidence intervals there if you want to see those and you know what they mean. And as Sharlene said, that difference was not statistically significant. So according to the trial, we had to conclude that the study intradialytic exercise did not improve PCS. So what I'd like to do is just help to interpret that data for you. So if we first off look at the actual raw data, so the data that's highlighted there is the controls. So the participants have completed normal routine care, and this is their PCS data at baseline and at month 6. And to help orientate you with this data, so the US norm for someone who's healthy is around 50 units. And for every 10 units, that's equivalent to a change in 1 standard deviation. So you can see the quality of life of our patients is low, and it decreases slightly over the 6-month period. And you can see that the quality of life is similar for the exercise group at baseline, and it slightly increases over the period. So the first question that we need to ask, because we're so close to statistical significance, is was the pedal trial actually underpowered? And you could argue that the answer to that is no. So the pedal trial was powered to detect a difference of 4 arbitrary units in the PCS. Okay, so this would have required 87 participants per group, and we actually had 114 and 120 participants in the group. So we had sufficient participants to meet the power that we set in the study. And you'll note that perhaps in previous studies, intradialytic exercise has seen differences of up to 7 arbitrary units in PCS after an exercise intervention. However, you could argue that although we chose a cutoff of 4 arbitrary units to be clinically relevant, perhaps that number should have been a little smaller. So Ware, who actually generated the SF36 and did a lot of the original validation work on this, actually suggested that the minimum important clinical difference for this outcome measure was 2 arbitrary units. And that's because if you see a change in 2 arbitrary units of this score, then your odds ratio is increased of not being able to work or to be hospitalized or to increase in mortality. That would have required 200 patients per group. So we were adequately powered to detect the difference that we were looking for, but you could argue that we weren't adequately powered to detect the minimum important difference. Okay, so power concerns the final number of patients who are actually analysed in the study. So it focuses on this part of the actual analysis. So this is our flow of participants through the study. And when we talk about power, we're looking at that final analysis which occurs at this stage. But as we tried to publish this work, we did have some comments from reviewers about dropouts and withdrawals. So that focuses on this part of the study. And what we want to know is, are withdrawals a concern? So were there a greater number of withdrawals in either group, which might have actually influenced our results? Now, the primary outcome is known for 234 patients. So that's over 70% of the people that we actually recruited. So I think we did a pretty good job there, actually managed to keep people in the study as best as we could. And if you actually begin to look at some of the detail around those withdrawals, you can see there's 40 withdrawals in the exercise group and 15 in the control group. Only 1 event actually in the exercise group was actually attributed to the intervention. So there was only 1 event whereby a patient with type 1 diabetes who had autonomic neuropathy actually experienced some severe episodes of symptomatic hypertension that were possibly made worse by the intervention. There were no other actual serious adverse events which were directly attributed to the intervention itself. What you can see is that there are more participant decisions to withdraw, so there's 8 versus 4. And you can see that the physician recommendations to withdraw patients was also greater in the exercise group, 9 versus 1. But these numbers are still very small when you think that there's actually 234 patients that have gone forward to be actually into the final analysis. So in our interpretation, the withdrawals were not a concern and cannot explain the lack of a significant finding in the pedal study. Okay, so looking back at this idea of the fact that we do have a very close significance value of 0.006, and if we actually look at that confidence interval, if you understand that, you'll realize that it does sort of suggest that there may be an effect actually happening in this study. The question is why? Well, statistically, there must have been a very good correlation between the pre and post-test measures. That's the statistical reason for why we're so close to statistical significance. But let's try to get away from statistics and talk about the actual data again to try to explain to you what actually happened in the pedal trial. So the first thing that we need to know is that if there's actually a cause and effect relationship between the intradialytic exercise and quality of life, so if the actual exercise intervention did what we wanted it to do to improve quality of life, then there must be a mechanism or a mediator to actually allow that relationship to occur. So here are all the mechanisms or mediators that might influence the physical component summary in the pedal trial. So these are the secondary outcome measures that Sharlene mentioned earlier. And you can see for all of those, the secondary measures of health-related quality of life, these include the measures of SF36 that focus on energy and fatigue, the burden of kidney disease. Some of you might have heard of a questionnaire called the EQ5D, which is a general measure of quality of life. All of these were unchanged by the intervention. Exercise tolerance by peak oxygen uptake, and physical function limitations by tests such as the sit-to-stand test that you might be aware of, and gait speed, habitual physical activity by the IPAC, and activities of daily living by the DASI score, and fear of falling by the Tonetti scale were all unchanged by the intervention. So there's no evidence of a mediator or a mechanism to actually link physical activity that was completed during intradialytic exercise with quality of life. So we're missing one of those key bits of information to suggest there's a cause and effect relationship there. So nevertheless, there is about 2.4 arbitrary unit increase in the PCS. So why did that actually increase? And one of the things that's helpful to actually understand here is where the PCS score actually comes from. So on the slide in front of us, we've got all of the items of the SF36. And you can see that the first, in the scale in the middle of that slide, you can see the items that actually contribute most towards the PCS score as a summary measure on the right-hand side. So when we actually looked at these subscales, so the boxes in the middle, and we looked at each of these individually to see whether the pedal trial had any influence on those, the only subscale that actually showed a significant difference after the exercise intervention was roll physical. And it was substantially different. So 16 arbitrary units, very statistically significant. So you can see that the roll physical score is driving any change in physical component summary that I might have seen in the study. Now note that the physical function scale, the one at the top, which is made up of all of the questions that assess people's ability to actually complete physical activities, was not influenced by the study. Interestingly, this roll physical measure, it is influenced by things like self-efficacy and people's confidence. And we'll come back to that in a minute. So, what we're seeing here is a change in PCS. If there is any change in PCS in this study, it's been driven by roll physical. And this is a component of the SF36, which is particularly reliant and dependent upon people's self-efficacy or their self-confidence. It's a more general concept of how physical health impacts upon people's work and other activities. And it's very positively influenced by people's self-efficacy or self-confidence. So one argument could be that interactions from the actual experimenters who were working with the participants, so the physiotherapy assistants, may have actually influenced this value. And this is a typical picture. This is not actually from the pedal trial, but for those of you who've done exercise studies, either from being a patient or being a physio, you'll know that in these studies, it requires a lot of supervision and often a very positive relationship between the physio and the patient. And relationships like this, it's very well understood in the literature that it can lead to response shifts so that patients report more positively on their quality of life. And it does also improve their self-efficacy, so it improves their self-confidence. So it's not perhaps surprising that actually we're seeing this change in role physical after this interaction with the physios. Okay, so the story so far, there probably is a meaningful increase in PCS after the pedal trial, but it's very likely due to the experimenter effect, the fact that the patients have interacted with the physios, and that's had a positive effect on them during the study. So why didn't the pedal trial actually increase the PCS as much as we expected? Why didn't it increase the mediators or the mechanisms that we expected to improve, like exercise tolerance and physical function? And as Sharlene mentioned, we think this is probably due to compliance and adherence. So how often patients actually completed the sessions that actually were prescribed to them. And you can see that of all of the sessions that we actually offered to the patients, less than half were actually completed by the patients. And then when they actually did complete those sessions, were they actually able to adhere to the intensity and the duration that we'd actually set the patients? So could they keep up to the power output, and could they exercise for the time that we prescribed? And again, you can see that only 18% of the patients actually managed to do that throughout the study. And there are a lot of patients, over half, who had some form of temporary cessation. So they actually stopped exercising for a number of sessions because of some complication. And when we actually interviewed patients and completed other questionnaires with the patients, the most common reason for that was intercurrent medical events, and these were associated with some significant fatigue. Okay, so for there to be this cause and effect relationship between intradialytic and exercise and quality of life, as well as there being these mediators and mechanisms, we would also expect that there's a dose-response relationship. So as we give more exercise to the patients, as the patients are more compliant, we would expect there to be a greater improvement in our outcome measures. So we did some pre-specified exploratory subgroup analyses. So what we can see here are 3 outcome measures: the PCS, physical component summary, energy fatigue, and peak aerobic capacity by a graded exercise test. And what we've done is we split the patients into groups, and there's roughly about 30 patients in each group. And the patients are split depending on how many sessions of exercise they actually completed. So you can see the first column is of data for patients who completed less than 30% of their sessions that we prescribed. And then the second, third, and fourth columns are for increasing amounts of compliance. So the first thing to note is that in the patients who completed less than 30% of the exercise sessions, these patients saw a substantial decrease in their quality of life, a decrease in their energy and fatigue, and a decrease in their aerobic capacity. Okay, so there we can begin to see a group of patients who don't do very well when prescribed exercise programs. And this is because of their intercurrent medical events and the associated fatigue with those. However, if we look at our patients who actually then do more than 30% of the sessions, so they complete more than 1 exercise session of the 3 that we prescribed them every week, there is an improvement. The problem is that there isn't a greater improvement if they complete 2 sessions or 3 sessions, 50 or more than 70% of the exercise sessions that we prescribed them. So they do better than the patients who can't do anything, but they don't improve as they complete 2 or even 3 sessions per week. So there's a lack of a dose-response relationship there. And that's the same when we look at either PCS, it's the same relationship when we look at our energy and fatigue scores, and it's also the same relationship when we look at our peak aerobic capacity. So there is an improvement if our patients do something, but it doesn't get any better if they do more than 2 or more than 3 sessions per week. So probably our significance has been driven by patients who completed more than 30% of the sessions, but there's no obvious dose response. Okay, so this was a bit of a surprising finding to us. If we go back to our primary outcome measure, we thought we must be in contrast to the rest of the literature that's previously been done on intradialytic exercise. Surely every other study has shown an improvement in physical component summary, and our study was going to be the one that stood out as being an anomaly. So we reviewed the literature and we actually found that that's not the case. So what we've got here are all the review studies that actually that we could find that actually looked at physical component summary. And you can see in the first row there's the classic Hugh and Jacobson, the Cochrane review. They didn't actually do a meta-analysis on the PCS score, so we couldn't look at that data. Then the next 4 reviews showed no impact of intradialytic exercise on the physical component summary. A couple of the next studies showed that there was studies of high risk of bias and heterogeneity. And then when we actually looked at the next 3 studies, although they said they'd looked at intradialytic exercise, they'd also looked at exercise programs that were delivered extradialytically, so at home or before the dialysis session. And then finally, you can see in the final column there that a lot of the studies actually included progressive resistance training as well as aerobic and intradialytic exercise. So in fact, our study wasn't in contrast to the literature. We couldn't find any strong evidence that intradialytic aerobic exercise had that positive effect on this particular outcome. And interestingly, one particular review had a very astute finding, actually showed that in this Gomes-Netto paper, they actually showed that it was only progressive resistance training and not aerobic exercise that was actually successful at improving physical component summary and quality of life. Okay, so Sharlene mentioned about costs. So was pedal cost effective? And the answer was that because pedal didn't actually have a statistical benefit, then we have to conclude that pedal wasn't cost effective, but still having these costs here are quite helpful to allow us to understand exactly how much it costs to deliver exercise programs. And you can see we've got costs here for inside and outside of London. So to give you an idea about costs in and outside of a large conurbation, and looking at the difference in different staff to patient ratios. So you've got a range in costs there from about £400 per year to around £800 per year to actually deliver exercise per patient in your renal unit. Was pedal safe? Well, there were some adverse events, hospitalizations, but there wasn't an obvious increase in those rates in the exercise group. So we concluded that exercise was safe for these patients. To try to bring this all together, and this is a little bit speculative, but to help you to predict what might happen if you went and used an exercise program similar to pedal in your HD population, here's some actual potential outcomes for you. So the first thing you could choose to do in your renal unit is nothing. You could choose to allow your patients to complete routine care. And this is what, using the pedal data, we would expect to happen to your patients. We would expect their quality of life to decrease by about 2 arbitrary units per year. We would expect their fatigue to be 0 or not to improve or possibly get slightly worse. And we would expect their peak aerobic capacity to slightly decrease as well. So that's the data that we've taken from our control group. Now then, we identified that about 25% of our patients weren't compliant, and this was because of complications that prevented them from completing the exercise. So we would predict that you would likely see, if you delivered your exercise program to all of your patients, a similar rate. About a quarter of your patients would have complications, and those complications would be severe, and they wouldn't be able to actually improve their quality of life. Their energy and fatigue would get worse, and their peak aerobic capacity would get worse. Note that those complications are not due to the exercise intervention per se, but due to other intercurrent medical events. However, there would be a group of patients, about 3/4, who could potentially show some benefit. And you can see here some of the likely benefit that you might see. And this would potentially be achieved even from doing just 1 exercise session per week. And that's how much it would actually cost for you to actually get that benefit. However, was those benefits due to exercise per se? And I would argue that probably not. They're more likely to be due to the fact they've had a positive interaction with their physio assistants, and they've gained the confidence to be able to complete the outcome measures. Okay, so I'm going to hand back to Sharlene now just to finish off. So
all right.
Stop sharing.
Oh, I was going to say you could just stay with it, but let me. Okay, so now you're going to have to just bear with me while I do a very, very quick. Where's the stop door of Jamie's slides? Take a breath. Okay. Oh. Brilliant. Okay, so what are our future directions? What have we learned from delivering pedal? So firstly, in terms of study designs, a recommendation to power health-related quality of life studies to detect the minimal clinically important difference of 2 arbitrary units, and also to include attention control groups so that we're able to try and tease out this the role physical component part of the PCS. Determine the effect of alternative interventions, so looking at longer duration, but also really critically looking at whether we use progressive resistance training either together with intradialytic cycling or as an alternative type of intervention, even if that needs to be delivered extradialytically, because we know that that's quite difficult to deliver during dialysis. And then really importantly, as you know, we often hear, it's just so important to tailor the interventions and deliver them in partnership with our patients. So we need to allow patient choice. You know, people in the general population don't all want to do the same type of exercise. They don't all want to do it at the same time. They don't all want to be assessed and progressed in the same way. So why would we expect hemodialysis patients to, you know, to do the same or want to do the same? So we need to allow patient choice. We need to target barriers such as fatigue. So fatigue is the main symptom which is reported, and we need to look at interventions to help with that. And then, you know, really consider whether this is the best time to start delivering exercise training for this group of patients, or should we be looking earlier on in the patient journey? So in conclusion, the PEDAL study, it was the primarily aerobic intradialytic exercise program that could realistically be delivered as part of a commissioned routine care. In the inclusive sample, so we did have a very inclusive sample of patients, PEDAL did not improve health-related quality of life, and any benefits that we saw, as Jamie explained, were likely to be due to that experimenter effect, so the interaction with the physio assistants. When we looked at a pre-specified subgroup analysis, we found that there was a group of patients who were able to do less than one of those sessions that were prescribed a week, and those patients' health-related quality of life declined, but that is likely to be due to intercurrent medical events and fatigue. And then there are a group of more compliant patients, or more engaged patients, I should rather say, who were able to complete more than that one session a week, in whom the health-related quality of life did improve, but there wasn't an additional benefit of doing more than that one session a week. So just want to acknowledge all of the patients who took part in the study, the PEDAL team, particularly Peli Kufaki, who is the other part of the Three Musketeers in this, and all of the research assistants and physio assistants, and then the different trial steering committees. And I want to just end with this question again. So having heard the second part, so the interpretation that Jamie offered, if we ask again that based on the results that we've seen, would you advise your renal unit to invest in an intradialytic exercise program? So we'll leave you with that as a question, and Jamie and I'll happily answer any questions that anyone has.
Thanks for that, Sharlene and Jamie. A very interesting and thought-provoking presentation there. I know on previous GREX events that I've joined, I know that people like to put their questions in the chat. So if anybody would like to do that, then I can read out the questions. Otherwise, does anyone have any immediate questions now?
There is one in the chat already.
Okay. So yeah, I'm not sure how relevant this is. I'm not sure, maybe Jamie or Sharlene. So this is, does exercise increase sodium deposits in muscles during hemodialysis? I don't quite know the answer to that.
That's definitely for Jamie, not for me.
Jamie, do you know anything?
I don't think anyone's actually taken muscle biopsies and looked at that, but obviously sodium is really important in muscle contraction. So we would expect that there would be an influx of sodium into the muscle just as muscle contraction occurs. But I don't think there's any evidence to suggest that exercise leads to a harmful increase in sodium deposits in the muscle. If anything, although I think this is pretty controversial, but intradialytic exercise may potentiate the dialysis procedure and actually remove some uremic toxins, although perhaps not urea per se. But yeah, so I don't know if that answers your question, Abdul Hamid, but I'm guessing a little bit of what you're trying to get at there.
Right, thanks for that, Jamie. I actually had one question which I thought I'd just start, and then I'll move on to some of the other questions in the chat room. And it's just, I know you talked about the sample size, and I know you originally randomized, was it around 380 participants? So my question is, was the power calculation based on all of those 380 participants reaching the follow-up? Because obviously the 380 versus was it around 240 you had at follow-up is quite a big difference. So I guess my question is, do you think if all of those, is probably unlikely, but if all those participants reached follow-up, whether the trial results will be different?
Yeah, so the study was designed to account for dropouts and death. As I said, we needed 87 to get to the end of the study in each group, and we had 114 and 120. So we actually had enough to actually meet our power calc. Had all the other patients not dropped out and got to the end, then yes, I think we would have seen a significant difference. However, because there was no mediating effect and there was no dose response, I don't believe that difference was due to exercise per se. I think that difference would be due to the positive effect of the physiotherapy assistants and their interactions with the patients. So I think we would have seen a difference, but I don't think it was due to exercise per se. So the controversial, facetious way of answering your question might be, yes, we would have seen it, but we probably could have got the same difference if we'd just gone in and talked to the patients.
Yeah. Okay, thank you. Sorry, Maddie, I didn't realize, did you have any question? Do you have a question?
No, I didn't. I was, there are a couple more in the chat though. I was going to just, there's a comment and a question. The comment is, have you considered, oh, I've lost it now, hang on. Would the question more be, would you invest in an intradialytic aerobic exercise program versus an intradialytic resistance exercise program? And I think then there was a follow-up question about why have you designed the study only focusing on cycling and not resistance or combined interventions?
Sharlene?
Yeah, so I completely agree that that should be the right question to ask. And why did we design it that way? We designed it that way because we were answering the specific question of whether intradialytic cycling improved health-related quality of life. So although we included the muscle conditioning exercises, and Jamie will speak to this better than I can, because Jamie has tried to do progressive resistance training during intradialytic exercise, and that actually requires quite a huge amount of equipment, which is practically impossible to deliver in, say, a London-based unit. So we had to make do with offering some muscle conditioning, but we know that that obviously is nowhere near what we would need to deliver if it was progressive resistance training. Have you got anything to add to that, Jamie?
Yeah, just that the NIHR were very keen for us to assess a pragmatic program, and as exercise physiologists, we were desperate to deliver a progressive resistance training component. And the reality is that the studies have done that. We've done it, and other groups have done it. But when they do that, they're very heavily supervised, and they're often supervised by very well-trained staff. So we felt, and the NIHR felt, that for the program to be pragmatic, it needed to be deliverable by the current service providers, and that would be physiotherapy assistants potentially, and in as Sharlene says, in quite a restricted space unit. So it was just felt that we needed to evaluate intradialytic exercise on its own, because that was more pragmatic and more deliverable. And to be frank, we believe that intradialytic exercise on its own would have a positive effect.
Thank you.
I can see loads of questions
There's
coming
more
up.
questions.
Yeah.
There's another one, and this is interesting for me as well, is has there been consideration of doing qualitative aspect to measuring the patient outcomes, because surveys can be very repetitive and does depend on how you feel that day, which could be entirely unrelated to the exercise or your dialysis. And it might affect how they've responded to those questions. And I suppose I would actually add to that, and I know, Sharlene, we've talked about this before, is I think there's a vast mental health aspect to patients sort of engaging with exercise and maybe getting the best from it when they're also managing their kidney disease and things. So are there other ways of measuring how the patients maybe reported how they felt and the outcomes?
So I'm not going to steal Kathy's thunder, because Kathy she's our qualitative expert who has done all of that, but it's not been published yet. But she's found some really interesting data that we're just in the process of writing a secondary paper which will include that. So I'll hold you on with that and not steal her thunder in such a public environment.
I look forward to that. I think, Nancy, it was your question, wasn't it?
I think you're on mute, Maddie.
Sorry, I was going to keep going through unless you want to pick any of them up, Dan.
No, it's fine. I think so the next one is from Hater, and it's interesting. In Brazil, we have more resistance exercise programs than cycling being delivered during dialysis. This cost seems to be low, and the equipment seems easier to handle. I know, Jamie, you sort of perhaps answered that with your
Yeah, it would be interesting to hear from Hater how they actually deliver that. So who's delivering it? And when we say that the equipment's easier to handle, I wonder what he means by resistance exercise. So whether he means TheraBands, ankle weights, etc. So it'd be great, Hater, if you could put in the chat or just tell us how it's actually delivered in Brazil, because I'd love to learn from that.
Yeah, I think you mentioned, Jamie, that yeah, from your perspective and from our experiences at Leicester as well, intraDialytic cycling during dialysis is definitely easier and requires less supervision. So I suppose if we're trying to implement these interventions into clinical practice, then certainly in a dialysis unit in the UK, then I think that would be easier to implement than resistance training. But yeah, it would be interesting to see how, as you said, how Hater delivers the resistance training in Brazil, and what he means with when he says resistance training as well. So yeah, we'll move on to Paul's question. So given the PCS construct component finding, was there a sense the exercise arm was more active off dialysis? Actually, yeah, sorry, Jamie, I just had one of your questions going back to the consort diagram. It was interesting to see that I think there was twice as many transplants in the exercise arm than the control arm as well.
Yeah, that's a good point. I don't know, the decision-making process of the transplant team can be quite heavily influenced by the fact that someone is participating in physical activity. So I don't know whether that influenced that or whether it was just luck. That'd be interesting to know. So the Paul's question is great, and we actually had measures of habitual physical activity as well as accelerometry to actually understand whether our patients were doing more work off dialysis, and the sense that we got at the moment is that they weren't actually doing more physical activity off dialysis. So although there might be that improvement in self-confidence and self-efficacy, it doesn't necessarily translate that they're then doing more exercise outside of the actual exercise program. But I do think that Kathy's qualitative analysis will show that there were some individual patients who participating did have a positive effect on their other activity that they were doing in their life. But at a group level, we didn't see that.
And I'll just follow up on your transplant question, because I think most of them were actually from King's, the transplant transplanted people, and it was, I think, more luck than it being an influencing factor. However, what was interesting is seeing those patients on the other side. So during our transplant exercise clinics, and the people who had been involved in the pedal trial were much less fearful and much happier to start exercising during, after their transplant. So I think that it had a very positive effect in that way.
Thanks, Sharlene. So we just had a question. Sorry, Hater's put the, I think he's just put the link to a study, a survey study in Brazil, looking at the different types of exercise that were delivered in the dialysis units nationwide there. So this question from Anthony: does this mean we just need to put a greater value on what we do? Easy and cheap to implement is one thing, but it isn't effective. Then a different model is probably needed, and we need to sell that, despite that being difficult in tight healthcare budgets. Sharlene, what's your thoughts on that question?
So I'm presuming we're sort of saying that we would, potentially, if we were able to hire people who were either sort of physiotherapist level or exercise physiologists to deliver a resistance training program that we felt would be beneficial. I would imagine that that would certainly be a good argument. However, especially post-COVID, with the financial situation being so difficult, I think we were going to struggle to sell a intradialytic program which had physio assistance at the costs that Pedal came out at, to deliver this across, certainly across the UK. So I think it's difficult. I'm not saying that we shouldn't be looking at a different model. I wouldn't say it's easy, and it was particularly easy and cheap. So there was still, the obvious cost of exercise cycles and the physio assistant staff to deliver it. It's just that, would it be better to use no equipment and spend a bit more time, talking with the patients and, potentially delivering a completely different type of exercise intervention that the patients want to do. It might be using virtual reality. It might be doing something online while you're exercising. It might be doing something off dialysis. So I think there's lots of different options that we need to look at, but I think we always come back to the fact that it should be individualized, and actually just taking any one program. If we swapped it over to progressive resistance training, not everybody wants to do progressive resistance training either during dialysis. So I think this is where we need to utilize our expertise and prescribe individually for people if we're able to.
I think to add to what Sharlene said there, I completely agree with you, Sharlene. I think Anthony's hit the nail right on the head, really. And when we were presented with the data from the pedal trial, Sharlene, myself and Pelly went through a real sort of period of trying to ask ourselves, what would we do now we know this data, and what would we do, how would we advise our renal units? And I think that the conclusion I came to was that when interventions like this are expensive, the question is not, do we offer exercise to our patients or not? It's when or what type of exercise do we offer to our patients, and what's the most efficient way of doing that? And we've got to remember that whilst we're exercise physiologists, we think that exercise is the most important thing, but a trust that's delivering healthcare has very many needs on its limited resources. So if I wanted to truly answer that question, where do I think that money is best spent, I would have to say that doing intradialytic exercise on patients who are on hemodialysis, I wouldn't put that money in that basket. I would put it somewhere else earlier in the patient's journey to have a more positive effect. Having said that, there is an argument, of course, that offering patient choice is very important. And in an ideal world, you would allow all patients to have a choice to exercise when and where they wanted. And I wouldn't want to take that away from patients. So it's a real conundrum of what we believe personally and what's actually practically possible to implement. And I take Kristen Parker's point. She said later that if we remove the input of our kinesiologists, physios, etc., then we'll end up actually having a negative effect and increasing costs. You know, we reduce patients' functionality, etc., and increases in transport. I completely agree. It's just whether the best time to intervene is during dialysis with intradialytic cycling alone. That's the thing. That's the thing I'm beginning to question.
There is a question as well, as you suggested, that just attention regarding physical activity could have improved the patient outcome. Would you recommend dialysis departments start with somewhat regular visits from an exercise professional, as is often done by dietitians? I was going to say actually with Beam as well, which is amazing, kidney Beam that Sharlene's launched, and but it's really frustrating as a patient if you're seeking an exercise professional to support you and they're terrified and won't go near you because you're on dialysis. So even those patients who are trying to do that, people won't train them and they won't work with them in gyms, and there is no recognised rehab programme externally for kidney patients, whereas I think cardio, there is more of that sort of thing. And I think that in line with anything that happens in the unit would be really powerful to kind of develop exercise professionals externally who understand this and can support the unit in what they're doing as well.
Yeah, I think this is something that we've all talked about for many years. Jamie and I have often said, you can go on a cardiac rehab course as an external exercise professional, but there isn't something similar which is delivered for renal or for chronic kidney disease. There is something being developed, but I don't know if I'm supposed to say too much about it, but by the GREX group, which will hopefully help with that. Yeah, I can completely agree that actually the problem is there's not always a professional to go round. I think this is our difficulty, is that we have a lot of dietitians in our units. I'm talking from a UK perspective. We have a lot of dietitians in every renal unit. We only have a few units in the UK where we have a physiotherapist or an exercise professional that's actually attached to that renal unit. So, I would of course advocate for that all renal units should have that, and it would, that would really benefit people just being able to speak to an exercise professional about an individualized prescription, or to get ideas, or just to get the self-confidence. I think, the fear of exercising is often what puts people off doing anything on or off dialysis. So I think, having that confidence is really important. But I think we're in a situation where we just don't have those professionals in the units at the moment. Not in all countries. I know Kristen will be able to, I know that you do a great job with all the kinesiologists across Canada. So I think there are some places which are better set up, but not at the moment in the UK.
It'd be great if Paul could put a link to the MFIT study. If there's any details on that as well.
Yeah, I'm not familiar with the MFIT study. So yeah, if Paul could perhaps put a link in the chat, that would be quite useful. Does anyone have any other questions? I think, go on, sorry, Jamie.
I was just going to say, Anthony's put another comment there about potentially getting dietitians to advocate. And I think that's one of the things that it was a tricky balance with PEDAL. We were using physiotherapy assistance, but we were using an intervention that we thought could eventually be delivered by other members of the multidisciplinary team who weren't necessarily exercise physiologists or kinesiologists. So I think ideally you would have that situation whereby all of your team are advocating for exercise. And yeah, watch this space on GREX, because there is something in the pipeline about offering that training to other individuals and not just exercise physiologists.
And I have to say, there are a lot of dietitians out there that do advocate exercise, and I think somebody's got put a comment in saying they get lots of referrals from their dietitians, and we do as well. I think, looking at holistic management in the renal unit, diet, exercise, mental health, all go hand in hand, and actually the closer those, that team works together, the better the outcome, I think, for the patient, definitely.
And Sorry, just about to wrap it up, but yeah, Nancy, so something to consider is acknowledging bringing in everyday activity and movement along with learning energy management combined with intradialytic exercise. And the patients are intimidated by the idea of doing 3 days a week.
Completely agree, and you'll have seen from our data that fatigue was a major barrier to exercise. So that energy management, and I heard you talk about this when I came to visit you, Nancy, in Canada. So yeah, I completely agree with that. And I think one of the things that we've noticed is becoming apparent now, there is an exercise guideline which is pretty much adopted in the US, Canada and the UK, of a target, an arbitrary cutoff of how much exercise we need to do for benefit. But when you actually look at the data in detail, you see that there is a curvilinear response. So if patients are currently sedentary and they do some exercise, they have more of a benefit than, say, someone who is potentially going to be pushing to 3 or 4 days per week. So bearing that in mind, I think if you are intimidated or your patients are intimidated by doing 3 days a week of exercise, if they're doing nothing and they do 1 day a week, then the data suggests that they will see a benefit. I think as an exercise physiologist, the caveat we would add is that that exercise that they do needs to be efficient. So it does need to be of moderate intensity. So it needs to actually have the benefit. That there is, unfortunately, perhaps some truth in the saying of no pain, no gain. And that's sometimes hard for people to accept, but it doesn't necessarily need to be 3 days a week and more to try and get the benefits.
Yeah, I think we talked about this before, Jamie. You don't necessarily feel the immediate benefits of exercise when you go from being quite sedentary. So I think Paul's actually just put in the chat that it's early days for MFIT and he will distribute the protocol online following this meeting. So I think that's wrapped us up for the hour. Maddie, do you have anything to add?
No, it's been really interesting. Thank you, Sharlene and Jamie, and everyone for joining.
Yeah, so I just echo that. Thanks again, Sharlene and Jamie, for a really, really interesting presentation and discussion following that. And yeah, it just leaves me to say thank you to everyone and thank you for all the participants for joining.
Thanks,
Bye.
everybody. Thanks for having us.
Great to see you.
Bye.
Bye.
Bye. Thank you.
Thanks.